Morning, students. In this journey of infectious diseases in general pathology, we will be talking about leprosy. As you all know, leprosy is a very well-known disorder known as the Hansen's disease. But today, in brief, we'll just be talking about the definition, the modes of transmission, the risk factors, the different types, classifications, and the clinical features. Basically, what is leprosy? Leprosy is a term not to be used because it is associated with social stigma. So better to be addressed as Hansen's disease because it was discovered by Dr. Hansen. It is an infectious disease caused by Mycobacterium leprae, which involves predominantly two organs, that is skin and peripheral nerves. Skin leads to cosmetic disfigurement and peripheral nerves leads to the different types of deformities of the hands and foot. Leprosy is a disease of the ancient civilization of China, Egypt, and India. The earliest documented case was way back in 1550. It was discovered by Gerhard Armor Hansen in 1873, hence known as the Hansen's disease. The most important feature or the key fact about leprosy is that it is a very chronic disease that is caused by acid fast, that is does not take up the acid stain, rod-shaped bacillus known as the Mycobacterium leprae. The most important feature about this bacteria is that unlike other mycobacteria, it does not grow in artificial media or even in tissue culture. For example, as you can grow the tubercular bacillus in Algae medium, this bacilli cannot be grown in artificial media and neither in tissue culture. It grows very slowly, indolent, takes around 5 years, average 3 years. Symptoms can appear as long as 20 years, not highly infectious, but it spreads very fast via droplets from the nose and mouth with close and frequent contact with untreated cases. Untreated leprosy can cause progressive and permanent damage to the skin and the nerves. Hence, leprosy, it is not a disease that can cause death, not highly infectious. If diagnosed early, there can be full treatment, whereas if untreated, can lead to progressive and permanent damage of the skin and the nerves. The exact mechanism is not known. Mostly it is spread by contact between cases of leprosy in healthy person by droplets, mostly by nasal discharges. It can occur in all age from early infancy to very old age. Close contact, that is contact of patient with leprosy, have a high risk of developing leprosy, and also people who live in areas of leprosy where it is endemic. Immunocompromised patients are more susceptible to infection. There has also been a link of the armadillo exposure, that is leprosy is enzootic in the 9-banded armadillo. There are two classifications. One is the skin smear classification by WHO and the clinical classification most commonly followed, that is the Ridley-Joplin classification. In the skin smear classification, WHO just has two classification of leprosy, posse and multibacilli. From the word posse itself, you can know few bacilli. That is skin lesion in which bacilli are few, that is 2 to 5 skin lesions with negative skin smear result. Skin smear is taken from the back of the ear, from the back of the pinna. There are only 2 to 5 skin lesions with negative skin smear, that is paucibacillary. Whereas multibacillary is any form of leprosy in which the patient shows positive smear at any side. Now the Ridley-Joplin classification is more commonly followed. You have the indeterminate leprosy, tuberculoid leprosy, lepromatous leprosy, and borderline leprosy. Borderline leprosy is also of 3 types: borderline tuberculoid, borderline, and borderline lepromatous. This is a differentiation chart in which that shows you the difference between skin and the nerve lesion. Most important for you to understand is that the tuberculoid or the borderline tuberculoid is at the lowest end of the spectrum, that is least infectious. In the middle you have borderline and borderline lepromatous, and the worst part of the spectrum and the highly infectious part is the lepromatous leprosy, in which there is high acid fast bacilli load 4 to 6%, there is hyperesthesia, there is nerve palsy, there is acral and distal symmetric nerve deformities. The middle part, hyperesthetic or anesthetic skin lesions, there are nerve trunk palsies, whereas the lower end of the spectrum, tuberculoid and the borderline tuberculoid, you have anesthetic and early skin lesions. Now, skin lesions are usually anesthetic. Anesthetic means there is loss of sensation because of nerve damage, And secondly, you can find hypopigmented or erythematous patch or plaque. That is, there will be loss of pigmentation of the skin or the skin will become red. Second, there can be complete or partial loss of sensation. Now, what happens with this neuropathy is that the patient does not understand any wound or any trauma. So, there are painless wounds, painless burns, there is paresthesia, there is tingling or numbness, there is thickening of peripheral nerves, there are lumps or swelling in the earlobes or the face, and there are tender peripheral nerves. You see, this is indeterminate leprosy, hypopigmented patch, sensation is normal, no palpable peripheral nerve, and slit skin smear negative. Now this is tuberculoid leprosy. In tuberculoid leprosy, you can find those fungal type lesions, that is annular, that is round, erythematous, that is red, anesthetic patch with well defined and raised borders, that is slit skin smear negative. Now how do you differentiate it from a fungal infection? First of all, irregular borders and anesthetic, that is there is loss of sensation. You can see hypopigmented also, that is there will be difference a shade lower than the adjacent skin. Here you can see now from hypopigmented it is getting to raised raised peripheral borders. Now this is the worst end of the lepromatous leprosy, in which you can find the fully developed lepromatous nodules in the hands, in the skin, on the face, on the earlobes. This is borderline leprosy. Now claw hand due to median and ulnar nerve damage, and hands showing neurotropic atrophy. Now coming on to the pathogenesis. The area most commonly affected by leprosy are the superficial peripheral nerves. Because the superficial nerves are involved, they will be thickened and you can palpate them. The second area that is involved is the skin, the mucous membrane of the upper respiratory tract, the eyes and the... Now, in tissue, damage is caused by degrees to which the cell-mediated immunity is expressed. For example, if CMI is low, bacillary spread and multiplication will be more. M. leprae is an obligate intracellular AFB with unique ability to enter nerves. The most characteristic feature of this bacteria is that it does not grow in artificial media, it does not grow in tissue culture, and it has this unique ability to enter nerves and damage nerves. Diagnosis is mostly by clinical signs and symptoms or by slit skin smear, that is from the back of the pinna you take a small slit skin and you observe it and with histopathological examination. In an endemic contour area, an individual should be regarded as having leprosy if he or she shows one of the cardinal signs. Number 1, skin lesions consistent with leprosy with definite sensory loss and with or without thickened nerves. First of all, you have a skin lesion. Second, you have a sensory loss, or you have or you do not have the thickened nerves or positive skin smear. If there is a suspicious skin sore, the doctor will remove the sample of the abnormal skin and send it for skin biopsy. Now, this skin biopsy is known as SSS, that is slit skin smear examination. With paucibacillary on histopathology, you will find no bacteria on AFB stain, whereas if it is multibacillary, it can be found. You see, this is how a safety margin of the normal skin is given. This is the skin lesion and with how an incision is made. We do not need to go into the treatment, but as you know, the common treatment is dapsone, rifampicin and clofazimine. There is a 6-month regime for paucibacillary TB with dapsone and rifampicin, and 12-month for multibacillary, in which along with dapsone and rifampicin you have to add clofazimine. Okay, complication, most important complication. Before we go into complication, the most important social and the emotional trauma to the patient is social ostracism. What is ostracism? Removal of a person from the society. That is, the people look at you with very bad, they give you very bad vibes, they give you very bad feeling that you're a patient of leprosy. So social ostracism is a thing that should be stopped at first. The second complication is disfigurement, obviously, because they're all facial patches and they're all lobules all over your face. The second complication is hair loss, particularly of the eyebrow and eyelashes. If you particularly see a leprosy patient, before the patient goes into full nerve damage, there are loss of hair in the eyebrow and the eyelashes, muscle weakness, nerve damage, nosebleeds, iritis, that's inflammation of the iris, infertility and kidney failure. Just a chart to show you the WHO recommended multi-drug regimes, and these are the references. So with this, we end our lecture on leprosy.